Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video. And here we have a patient who suffers from a condition called hyperacusis, which is where this patient is very sensitive to sounds, and sounds that for me or for most of the population would be soft or moderately loud, this patient would find extremely loud. And for that reason, we're going to attempt to remove this patient's earwax without using microsuction, which can be a noisy procedure. And therefore, I'm using the Rai Angled Curette here. Fortunately, they had just the right consistency of earwax to remove with the Rai Curette. And as you can see, slowly but surely, I'm scooping out all this soft wax. And even at this stage, this patient's hearing was significantly improved because, as you can see, we can fully visualize their eardrum in the distance. They have got quite a bendy ear canal. You may have noticed on the right hand side, the anterior canal wall is quite prominent, and most of our ear canals are quite prominent. We have a bulge on the anterior canal wall, and then the ear canal curls beyond that bulge and it creates a recess. So at this view, we can't see the full eardrum, we can't see the anterior recess. So it gives you an idea of the architecture of this patient's ear. Now, what they did have is a lot of hidden wax. So as you enter the ear canal, posteriorly, there's a little blind spot. So in the case of the right ear on the left-hand side, you can quite often get wax hidden there. So we're going to spend a bit of time now entering that blind spot to remove all the wax. So as mentioned, in terms of their symptoms, it's completely alleviated. But whilst this patient's here, we're going to see if I can remove some residual wax. Now, this wax you can see here, it's on the cartilaginous portion, and I've just angled the Rai Curette so the curvature mimics the floor of the ear canal. So if I wanted to remove wax from the front of the ear canal, from the roof of the ear canal, sorry, I would actually invert this instrument. So this instrument that I have, there's a curette on either side, and the angulation is the opposite. They're diametrically opposed. So no matter which part of the ear canal we're working on, I can manipulate and rotate the Rai Curette to ensure the curvature of the curette is aligned with the curvature of the ear canal. And that just allows for more seamless removal of the wax. We can glide a bit better on the canal wall without it being uncomfortable for the patient. So this is the little blind spot. Just, you can see we're just scooping that out. They did get a bit of a cough reflex here. So on the bottom left-hand side of the ear canal, we have a branch of the vagus nerve called the Arnold's nerve. And some people have Arnold's nerve oversensitivity, or hypersensitivity, should I say. And if you stimulate the bottom left-hand side of the ear canal, you can get a stimulation of the Arnold's nerve, and as a result, some patients experience the gag reflex, some patients experience a cough reflex, some patients, and I suffer from this, I get runny eyes because the Arnold's nerve also connects to the lacrimal glands, which are your kind of tear duct glands on the corner of each eye. Some patients can suffer from auditory syncope, or better known as the vasovagal response, and they can actually pass out. So the vasovagal response is when your heart rate lowers, your blood vessels dilate, which in combination leads to a reduction in blood flow to the brain, and patients can experience a brief loss of consciousness. It is quite scary when it happens because you can see the patient's eyes run to the back of their head, and they literally fall dead weight. And so quite often they may go over to one side. So if they're sat on the ENT chair, you just have to make sure they don't fall off, although I've got armrest on mine. And it can be quite scary actually, because you kind of worried for a moment, because they literally have passed out. But it typically lasts for no more than, I would say, 30 seconds. And when patients wake up from it, they are they're totally bewildered. They're not sure what happened. So when you explain to them they passed out, they were quite surprised. And if that ever occurs, you just want to loosen any of their clothing. So you just want to allow for more blood circulation. Whilst they're passed out, and if they're on the laying down, you want to try and lift their feet above their heart, so you're kind of redistributing the blood flow towards the brain. Open the window, give them a glass of water, and if they're driving, you just want to make sure they're sat in the clinic and until they're completely fine. It's kind of a rare occurrence that patients suffer from the vasovagal response. I've probably had 4 or 5 people in my whole career. I had 2 in 1 week actually, which is a bit frightening at first. But it can happen, and actually it will happen. So if you are performing wax removal, that is going to happen at least once in your career. So I'm just cleaning their right side. On this side, they've got some maringular sclerosis, which is calcification of the eardrum, some scar tissue. So you get calcium depositation in the middle layer of the eardrum. So this patient had grommet T-tubes, or ventilation tubes as I think they're called in the US. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.